Now I'd like to invite Professor J. Titiyal. Everybody, we all know him very well. He's a excellent teacher and also a great orator, and he has been known in India as well internationally. So over to you, sir.
Yeah, thank you. Thank you. Making me visible. Thank you, chairpersons, and I'd like to thank KSOS organizing committee for a kind invitation. I'm going to talk about something which is not unusual or uncommonly seen, a defect in the posterior pole during your surgery in a posterior polar cataract. I can see some young people sitting here. They all would be doing surgeries for cataract. And we all understand posterior polar sometimes can be challenging for all of us. So what is this pseudo hole which people have described earlier, which I have renamed as an intraoperative PPCDD? I'll come to that. What is this sign? No financial disclosure from my side. These are various clinical presentation of posterior polar cataracts. They would be in a different shape, different sizes, different color, or different type of morphology as far as examination is concerned. They all give you different challenges, and we know that how to perform surgery is classically been described, and you people have been doing those surgeries also. Do a good capsular access of size, which safeguards your emulsification of phaco, as well as if you have a PC support missing subsequently, you can put the lens in the sulcus and capture that. And we all know have a slow motion phaco for a nucleus emulsification, which is a classical teaching for these cases. Do hydrodelineation first and avoid hydrodissection. That is a dictum for all cases, which has to be again clarified by various ways. So I've done a capsule exercise. I'll just take you through the emulsification part here. Normally, all cases will be softer cataract, which you can do delineation very, very nicely, and emulsification also can be done very clearly. So this is a layer by layer emulsification being done for a case with a softer cataract. Then subsequently take out the endonucleus of a cataract. You are left with the epinucleus core, which you have delineated to safeguard your posterior capsule, and the cortical fiber. So you can see this is the epinuclear cushion. As soon as we take out the epicortic, you can see the defect here in the middle. So sometimes you don't understand, is it exactly a defect in the posterior capsule, or it is just a defect which is pseudo defect in the posterior capsule. It is actually defect in the epicortical cushion area. So this is what people have described as a posterior polar in cataract as a pseudo hole, which earlier was described by Dr. Abhay Basavada from Ahmedabad and Dr. Osher from US. And subsequently, we did a study to understand what is the implication of this pseudo hole in terms of surgical outcome-wise. So this is a publication we published in a JCRS in a prospective clinical case series of posterior polar cataracts of around 67 cases. We described this sign as intraoperative posterior polar cortical disc defect sign. So this defect was seen in almost 87% of the cases, you can see here. In 93% of cases, a complete defect in the middle, and around 6% of cases, a partial defect in the posterior part in terms of posterior cortex or epicortex in these cases. It can appear after the nucleotomy. It can appear after nucleus completion of emulsification. Then when you remove epicortex, then you see this way when I'm trying to remove the cortex here. In a majority of cases, 90% of cases. This is after the epicortical removal. When actually removing the cortex, you see this defect coming up. Rarely you see immediately after the nuclear emulsification. So all these three types are different implication of morphology of these cases. So if you see in 9 cases of out of 67, we didn't see this defect. That is around 14% of the cases. And in those cases, we had almost 40% chance of a posterior capsule opening. That means if you see a disc defect during your surgery, you are sure that your posterior capsule is intact. You can complete your surgery as such. So this is one representative video which I'd like to show you that. This is again a typical posterior polar cataract, which sometimes can give you a little different appearance when actually you are doing surgery in these cases, if you're not sure that what type of case you're dealing with. So this is a case which sometimes can give you a challenge because this has a slightly harder nucleus. Sorry, this video has got hanged. So you have a slightly harder nucleus, so you have to do a different technology for these cases. I'll just go to the next case here. This is a case where we have again a posterior polar cataract. In this particular case, when I'm removing the epicortex here, so classically described as pull and leave it in the center. Pull and leave it in the center. Subsequently, you can take out with the irrigation aspiration technique. And this is the case where I could not take out the entire epicortex. That means the disc was attached to the posterior capsule. In such cases, you will not see a posterior polar disc defect in these cases. And ultimately, you will have a defect appearing in the posterior capsule. So this is the entire epicortex which is taken in mass. And you'll see subsequently there will be a defect in the posterior capsule. The idea here is if you don't see the disc defect during your initial cortical aspiration, then there's a very high chances that you'll have a posterior capsular defect here. You can see a large defect appearing here. So that should be understood. Therefore, if you can examine these cases beforehand by good slit lamp examination or do a OCT pixelization, you can do anti-segment OCT or you can do a microscope-assisted OCT like a IOCT microscope. So this is what you see, a large posterior disc and posterior capsule can be delineated clearly in these cases. This is one posterior polar cataract where you can't see the posterior capsule at all. And this is a case where you have a defect and entire cortex is bulging towards the vitreous cavity. So these would have a different morphology. So we scan almost more than 100 cases looking for which are the high risk shape of a posterior polar cataract which have a high chances of defect happening. So 3 shapes were identified. One is a conical morphology, second is a moth-eaten morphology, or you have an eclectic morphology. If you have these 3 morphology, you have a very high chance of posterior capsule opening. Like you see, we had around 10 eyes out of 100 eyes, and all of them had a very high incidence of rupture. And they all didn't have the posterior polar cortical disc defect sign. So if you don't have the sign, you have a different morphology, that is a high-risk morphology. We also published the pattern of cases with the intraop microscope in these cases. We classified them as type 1, type 2, and type 3. Type 1, where you could see the entire posterior pole clearly and you can delineate the posterior capsule throughout. In these cases, you can do both hydro delineation and dissection, and surgery becomes simpler. Type 2, periphery of posterior capsule can be delineated, but central area is difficult to see. So you have to be a little careful, only do delineation in these cases, don't do a hydro dissection in these cases. Same thing for type 3, which you can see a moth-eaten pattern. Posterior capsule cannot be delineated. It's like a higher risk morphology in these cases. If you see here in the OCT, you'll know I'm doing a delineation here. So when I inject the fluid, you'll see the fluid wave coming clinically, but you can see the amount of fluid has gone, and the space created by the fluid is also important, and it also tells you that you have a good epicortical cushion as well as pieces intact in these cases. So such cases, when you finish the surgery, you'll again see a posterior cortical disc defect like this, and you know that your posterior capsule is clean and intact in these cases. The defect sign is not exactly the defect in the posterior capsule, it is the defect in the cortical area only. If you see, type 1 has no chance of rupture, and type 2 and type 3 will have a slightly higher chance of rupture in these cases. So if you see a type 1, type 2, you can see the disc defect in these cases. Type 3, type 4, you'll never see a disc defect, so you have a very high chance of posterior capsular rupturing in these patients. If I summarize my talk, I have talked about 2 or 3 important things. During your surgery, if you see a posterior polar cortical disc defect, there's a safety sign for a posterior capsule. If you don't see that, that means entire posterior polar disc is attached to the posterior capsule. When you pull it, you're going to have a tear in the posterior capsule. So if you have access to anti-segment OCT and IOCT microscope, you can morphologically define these cases. You are sure that what is going to happen on the table, and you can counsel your patient accordingly, change your surgical plan on the table. It is so important to examine all these patients very, very carefully. Therefore, understanding the morphology of cataract gives you the understanding of what surgical technique you're going to do, and you can always correlate your technique with the outcome. Thank you for your kind listening.
Thank you, sir, for elaborating on posterior polar cataracts, which is itself a very difficult and challenging topic, and difficult to manage during surgery. So, but you have clarified a lot of things very well. Thank you.